Session 9 is about care coordination. We start by discussing roles of key members of the care team. We then delve into the wonderful and convoluted process of referrals and associated networks.
Primary care doesn't just happen with a primary care physician. There's an internal team within the office, as well as coordination with external referrals. Let's start with taking a virtual tour of a primary care office to see all the roles in action. Of note, in a fee for service system, most of the administrative and non physician clinical roles do not generate income. The other thing to note, it's generally recognized that for every doctor in the US, there's about 10 administrators, and each administrator costs money, which is often attributed to the rising cost of healthcare. Starting from the patient being called back from the waiting room is the medical assistant. The training for medical assistants varies. Some have certificates, and some are just pre-med students working in centers. And the skill set they require also varies. In some offices, medical assistants simply room the patients, maybe do some vitals. Others, they act more clinically and will do tasks such as cleaning out ears, setting up suture trays, and sometimes even putting on fiberglass splints in certain ERs. Then, after the medical assistant completes their task, they pass off to the nurse. The nurse can vary anywhere from a LPN, which is the lowest nursing degree, all the way up to an RN, which is a bachelor's plus a certificate. Nurses help with all sorts of tasks, usually higher skilled, including putting on EKGs, administering medicines, and sometimes nurses can even do certain types of visits. This is the only caveat to non-clinician staff billing for services. They have a special code 99211. Example of this might be an INR check, which is a certain type of level for patients who are on warfarin, or they can even do simple blood pressure checks and bill for those. Then around the office are ancillary services. You usually see these ancillary services much more robustly in value-based networks. So when value-based care practices talk about team-based primary care or primary care teams, they will frequently have health coaches, social workers, psychiatrists, some even dental. But in a fee for service, generally it's limited to, say, a health coach. And the health coach would be able to bill and is often a social worker and sometimes can do a Medicare well visit. And the doctor just signs off on the Medicare well visit after the health coach has done it. And that's one way that the social worker or health coach pays for themselves. Then you go further into the back office, you find all the admin. Certain offices, especially larger hospital systems, will have people specifically doing prior auth, helping patients with patient assistant programs, office managers who coordinate all the other staff, and schedulers, sometimes in the back, sometimes in the front office, helping patients schedule their follow-ups, patients who call in trying to get an appointment. Internally, there's a lot more to primary care than simply the doctor and the patient in an exam room. The ratio that's often thrown out is that for every doctor, there's 6 clinical staff and 10 non-clinical administrative staff. Now, moving outside of the office, one important function of primary care is the referrals. Primary care has been described using various analogies. When HMOs were bigger, primary care was often called the gatekeeper. That meant patients could not access any other part of the healthcare system without permission or a referral from the primary care doctor. Nowadays, more people talk about primary care as the quarterback, which means the person who coordinates multiple specialists as the player, I guess in this case, the football, gets passed around the healthcare system. And then more tech forward thinking people may think about primary care as Google Maps, helping the patient navigate from where they are, their disease state, to where they need to be, a state of health. The referral process currently is a fairly painful process. at least between practices. Hospital systems, not so much, but independent practices, there involves a lot of faxing. As people who are in healthcare know, faxing is still very much a prevalent thing. Even if it's e-faxing, it's somehow still considered faxing. What happens is a referral is made, usually through some sort of e-fax from the primary care office to the specialist office. Then the specialist office receives it, asks for records. If the primary care doc is nice enough, records will have been sent with the initial referral. Then they call the patient, or sometimes the patient has to call the office to schedule an appointment. Then the patient has to go see the specialist. Then they return back to the primary care office, and records are faxed from the specialist office to the primary care office. There's generally no communication between specialist and primary care doctor besides for the notes that are passed back and forth. And sometimes, as you may have known, there are many steps and a lot can fall through the cracks. Patient might not get called by specialist office. They might no show to their visit. Maybe the records didn't get sent over. Maybe there was an issue sending the initial referral out to the specialist. There's a lot of steps and a lot that can go wrong in that process. But earlier I mentioned that hospital systems, it's a little less painful. And the referral process is actually quite different when you look at hospital systems versus independent, smaller private practices. Hospital systems generally incentivize their primary care docs to refer internally. Now, I think legally they're not allowed to do so, but they make it so much easier to refer internally than externally. For example, when I was in residency in a larger hospital system, when you hit refer, it automatically defaulted to the internal person. You can choose external and pick somebody, but it was just so much easier. Also, because I worked in a hospital system, I didn't really know who the outside specialists were. So by default, it was easier just to have somebody go in from the system. The other benefit was referring internally, you automatically get their records and the referral goes out a little easier. When you think about hospital systems and incentivizing their primary care docs to move faster, see more people, it all leads to increasing referrals. And when you increase referrals, it's generally assumed that the PCP will refer internally in the hospital system. When you go to private practice, this is where more of the multi-step issue comes into play because not everything is integrated and there's no frictionless communication. Generally, private practice docs do referrals based on networking that is outside of insurance. So one of the other benefits of hospital-based systems is that if a patient is seeing a PCP in a hospital system, there's a good chance everybody in the hospital system, inpatient, ER, and specialists, all take the patient's insurance. In private practice, not so much. The PCP might be in network, but then the GI or cardiologist that the PCP likes or generally refers to may not be in the patient's insurance network. So private practice, the PCP generally will start their referrals based on who they know or who they've heard good things about. And then based on insurance, may have to find alternatives. As of now, there's no good quality, objective quality metric service that PCPs use or can use. That being said, there are different ways that networks are built. And while it's primarily relational for primary care docs, there are certain criteria that a lot of them will look at. Number one, quality. Reputation is a bit of a surrogate for quality in a local community because people talk, and generally in the medical community or the patient community, the right people will know which doctors are good and which aren't. The other consideration, and this is largely for the direct primary care community, cash pay. Certain specialists, especially private practice, will list their cash pay prices or will offer it up to PCPs who ask for them. Hospital systems are a little less transparent and it's harder to get these pricing, but a lot of times they will do some client billing as well. Insurance, of course, is a given, just understanding which specialists take what insurances. That's also a fairly opaque process and generally figured out by trial and error. Certain companies will hold and gather quality information, but individual practices don't have access to this. Usually it's larger practices or certain services that work with larger self-employed companies. A well known one is Healthcare Blue Book. In the health tech space, Ribbon lists specialists and helps with care coordination. In the employed space, there's Nomi, which is a newer company that's also helping self funded employers figure out where to get the best contracts and the most transparent pricing. This conversation all started with talking about the complications of referrals. And there's one promising technology coming down the line, which is the creation of companies that leverage health information networks. These are companies like Zeus, Particle Health, and Health Gorilla. And what they do is they connect all the big health information networks into an API, which works with certain electronic medical records, so that instead of this faxing back and forth and patients having to remember where they were, oftentimes incompletely and incorrectly, with a push of a button, every health system that the patient has been in, the data will flow into either a browser or the patient's chart. And so this is a huge time save and something to watch in the care coordination space as it develops.
To summarize, we reviewed the structure of care teams and the roles of MAs, nurses, ancillary staff, and the admin. We also described the woes of making referrals in primary care, and this concludes session 9.